Hello Oncology residents. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center, New Delhi over 12 years. And I have been practicing and teaching oncology for more than a decade. I completed my MBBS and DMRT from CMC Vellore, did my DNB at Rajiv Gandhi Cancer Institute and later pursued a fellowship at Royal Marsden Hospital in London. I have also undergone a specialized training in cyberknife from United States. I have chosen a topic that I personally did not enjoy during my residency. I still remember sitting with different textbooks open in front of me and thinking, why is everyone explaining this differently? One book would start with one pathway, another would start with somewhere else. There were flowcharts everywhere, arrows leading to more arrows, sequences of molecular events, gene mutations, cell signaling, and honestly, it felt overwhelming. So if you have ever felt that way about this topic, you are not alone. Today, I am going to explain it the way I wish someone had explained it to me during my residency. I will keep the science intact, but I will try to present it in a logical sequence so that one concept naturally leads to the next. Now let me say this very clearly. If you do not understand anything or everything in this first attempt, this is completely fine. This is not a superficial topic. It requires repetition. You may have to watch this video again, and that is normal. In fact, I would suggest that after watching this, do not immediately jump to read from other textbook. If you mix multiple explanation too early for this topic, you may end up more confused because every author structures the mechanism slightly differently. The first half of this lecture will feel more intuitive and clinically relatable. The second half will go deeper into molecular details, and there you will need to concentrate a bit more. So stay with me. We will build this step by step. Let us begin. Before I bring up the first slide, I want you to think about your last few OPD days and ward rounds. How many oral cancer patients did you see in the last week? 10, 20 or more? In India, especially in North India, oral cancer is extremely common. In many radiotherapy departments, a large proportion of machine time is occupied by head and neck cancer patients, and a significant share of those are oral cavity cancer. For us, this is not an occasional diagnosis. It is our daily routine practice. Unlike in Western countries where head and neck cancer are merely 3% of their total cancer. Because we Indian oncologists encounter it so frequently, there is a risk that our approach becomes narrowly disease focused. We see the oral ulcer or growth, we take a biopsy, we do surgery, we give radiotherapy, and after this we put the patient on follow-up and move on to treating next patient. But this is not enough. You are training to become oncologist, and oncology is not just about treating the current tumor. It is about providing holistic care. Our responsibility is not to just treat the current cancer. We must also counsel treated patients to permanently discontinue these habits because continued exposure to carcinogens increases the risk of recurrence, second primary, and poorer outcomes. We must also counsel normal individuals who currently smoke, chew tobacco, or consume alcohol and are at risk but have not yet developed cancer. We must actively engage in smoking cessation and tobacco cessation strategies. When a normal person comes to your OPD and asks, "Doctor, I have been smoking and drinking alcohol. Am I at risk of developing oral cancer?" Is it enough to just give the MBBS level answer? "Oh yes, you smoke too much, you chew too much tobacco and that is why you have a risk of developing cancer. No, this is not enough anymore as an oncology trainee. When you get an oral cancer case in your exams and your examiners ask you, doctor, tell me what is the etiology of your patient having oral cancer. Is it enough to just give the MBBS level answers? Sir, tobacco smoking, tobacco chewing and alcohol. No, this is not enough anymore as an oncology trainee. At your level, you need to know exactly what happens at the molecular level when someone chews tobacco, smokes or consumes alcohol. Remember, oncologists and cardiologists are the two specialties who need to know about smoking and alcohol in much more details. We need to know about the mechanism of how these three habits lead to adverse health effects. A general physician, an orthopedician, ophthalmologist, gynecologist may get away by just knowing the causes of oral cancer as being tobacco smoking, tobacco chewing and alcohol, but not you. Today, we are not just going to list risk factors of oral cancer. Any medical student can do that. We are going to dive deep into the mechanism of how these habits lead to oral cancer. We are also going to look at the Indian context of this disease. If you do not understand how oral cancer are caused by these habits, you cannot counsel effectively. You cannot prevent recurrence adequately. You cannot contribute meaningfully to public health efforts in smoking and tobacco cessation programs. With that perspective in mind, let us begin. This is IARC Classification System. IARC stands for International Agency for Research on Cancer. IARC classification is not just another publication or paper. It is the global gold standard for determining whether an exposure or habit truly causes cancer. Guys, when IARC classifies something, it does so after reviewing decades of epidemiological, experimental and mechanistic data. IARC is not opinion. This is an evidence synthesis at the highest level. As you can see on this slide, the latest 2026 IARC categorizes agents or exposures into 4 different groups based on the strength of the scientific evidence available till date. Group 1. Group 1 has those exposures which are called carcinogenic to humans. There are currently 135 agents in this category. For these agents, we have sufficient evidence in humans. Sufficient evidence. It means a causal relationship has been firmly established between exposure and cancer. It is not just suspicion. It is not just correlation. Its causation is proved in humans. Group 2A has those exposure which are called probably carcinogenic. Probably carcinogenic. With 97 agents, this group is used when human evidence is still limited, but there is sufficient evidence of carcinogenicity in experimental animals. Group 2B. Group 2B has those exposures which are called possibly carcinogenic. Possibly carcinogenic. This category includes 324 agents. In these cases, the evidence in humans is limited and the animal data are not conclusive. There is concern about their being carcinogenic, but not certainty. Group 3. Group 3 has those exposures which are not classifiable. This is the largest group with 499 agents. In this category, the evidence is simply inadequate to reach a conclusion in either direction. These are the types of agents or exposures IARC has listed relevant for head and neck cancer. As you see, several exposures have been evaluated. This is a list of group 1 carcinogen. This is a list of group 2A carcinogen. However, when we specifically look at oral cavity cancer, something striking emerges. Out of so many exposures, only 3 exposures are clearly placed in group 1 for oral cancer. These are tobacco, areca nut and alcohol. Tobacco, areca nut and alcohol. Again, I am reminding you that these are not just causal association. These are high certainty, causally established carcinogens in oral cancer. This is a list of common encountered events in patients with oral cancer. Chronic mucosal trauma, poor oral hygiene, high sugar intake. At this point of time, they are not proven to be etiology, but they could be contributing factors. These are not listed in IARC, but there are research going on to see if they actually cause cancer. Today, I am going to take you to a deep dive into these 3 habits, one by one, and understand the exact mechanism at molecular level leading to oral cancer. Let us first discuss a very important topic. Trust me, Indian examiners love to grill PGs on this. Remember, if you come to know that your examiner is from TMH, you better be thorough about this the previous night. See, all of us keep reading about MRI, PET CT, surgery, radiation, chemo, immuno, but we hardly pay any attention to this topic. This topic is etiology of oral cancer. Whenever we read about this topic from books, we tend to ignore it. We think, ये तो आता ही है, इसको भी क्या पढ़ना? Even non-medical को भी पता है ये तो. Time waste होगा. सीधा diagnostic workup ही पढ़ लेते हैं. I am again telling you, 2 specialist oncologists and cardiologists has to know much more about smoking and alcohol. If you open any standard Western textbook such as Devita or Perez, the chapter on head and neck cancer feels different. When they talk about etiology of head and neck cancer, they focus heavily on the etiology of pharynx and larynx. They say smoking and alcohol as the major etiology of these cancers. But if you walk into any cancer OPD in India, especially in North India, you will see a different scenario. You will not see as much larynx and pharynx. You will see a lot of oral cavity cancer. You will see a lot of buccal mucosa. You will see tongue, don't you? Why is this? It is entirely because of a specific endemic habit in India, tobacco chewing. Indians chew tobacco in many forms such as pan, tambaku, khani, gutka. We need to stop teaching our residents that smoking and alcohol are the main etiology of oral cancer in India. In fact, I see many a times that when examiner asks a resident in their case presentation, what is the etiology of your patient for developing oral cancer? The resident answers, sir, smoking and alcohol. See, smoking and alcohol do cause oral cancer, but the main etiology of oral cancer in India is tobacco chewing. Now, let us break down the components of a common form of tobacco chewing in India called as Paan-masala. You may find it unnecessary and funny to know this at this stage of your career, but trust me, it's important. You will be asked in exams. Often residents get confused what actually is Paan-masala. I can bet you many of you will realize soon that you didn't know this enough. Especially our South Indian doctors, residents who are not familiar with Paan-masala habits so well. Remember, Head and neck cancer are the commonest cancer in India. We need to know its etiology in detail. Look at this image. This is Betel Quid. Betel Quid. You must distinguish between the two types of Betel Quid. One is the Sada Paan, in which there is no tobacco. And the other is Zarda Paan, which contains tobacco. Let us break down the components of a typical Paan sold everywhere in North India. First is the betel leaf, this one. Many people think this is the carcinogen. It is not. It is harmless. It is nothing but a wrapper. It holds the mixture of Paan-masala against the mucosa, allowing for contact time. Now look at the second component of Sada Paan. It is slaked lime. It is called chuna in Hindi. Can you see that white paste over the betel leaf? This is slaked lime. This is actually calcium hydroxide. We will talk about it, what it does soon. The third component of Sada Paan is the areca nut. Areca nut. We North Indians call it supari. Supari. You must have heard it often from your patients. This is the primary culprit in Sada Paan. It has a very, very important active carcinogens. You need to remember its name. Pay attention, please. It is called arecolin. Arecolin. So actually, amongst the three components of Sada Paan, betel leaf, slaked lime chuna and areca nut, it is only the areca nut which has carcinogens and causes oral cancer. You need to understand two important things this arecolin does. First, it causes carcinogenesis. Remember I told you, IARC classification, it put arecolin under group 1 carcinogen. Second, it causes fibrosis. How does it do it? It upregulates collagen genes, leading to oral submucous fibrosis. So areca nuts having arecolin causes oral cancer as well as submucous fibrosis. Now what is the use of this slaked lime chuna? Why is it added in Paan? Because it improves the extraction of arecolin from the areca nut. It creates an alkaline environment in the oral cavity. This alkaline environment does two dangerous things. One, it causes microabrasion, minor trauma on the mucosa. When there is repeated minor trauma occurring for many years, it facilitates entry of carcinogen arecolin into the oral mucosa. Second thing it does is it generates ROS, reactive oxygen species, which cause direct DNA damage. Please remember, we have not talked about tobacco so far. So the Sada Paan having these three components does not contain tobacco. The question examiner often asks is, does Sada Paan causes oral cancer? The residents very often say, sir, since this does not contain tobacco, it does not cause cancer. This is a blunder mistake. Remember, it contains arecolin, which in itself is an independent group 1 carcinogen for oral cancer, as I showed you, IARC classification. Sometimes, patient from UP or Bihar will say this very innocently, sir, हम तो सादा पानी खाते थे, सुपारी कभी नहीं खाया, फिर भी कैंसर हो गया. It is a common misconception among laymen that Sada Paan without supari does not cause cancer. Now let us add fuel to the fire, tobacco. In this image, you are seeing raw tobacco leaves. Listen very carefully. These tobacco leaves contain another very powerful tobacco specific carcinogen called nitrosamines. This tobacco leaf is simply the leaf of tobacco plant which has been sun-dried and cured. Because it is raw, the concentration of nicotine is extremely high, leading to rapid addiction. The next thing you see here is the zarda. Zarda. This is nothing but a processed form of tobacco leaves. How is it made? They take the tobacco leaf and boil it in water, add some slaked lime, chuna, and add some spices such as saffron, cardamom, menthol, etc. They also often add vegetable dyes, giving it that characteristic color. So this combination of sada pan plus tobacco leaves plus chuna forms a deadly combination. Tobacco leaves contain nitrosamine carcinogens, areca nut contains ericolin carcinogen, and slaked lime chuna contain ROS. If a person consumes this combination, he gets a synergistic explosion of risk of oral cancer. This is all about components of betel quid you need to know. Tell me very honestly, did you know this? Now let us look at some numbers. Listen very carefully. I want you to memorize some numbers. I'm again and again reminding you, head and neck cancer are the commonest cancer in India, especially in radiotherapy department. We need to know everything about oral cancer. The numbers I am going to quote here are a potential exam question. If an examiner asks you, what is the evidence that tobacco chewing causes oral cancer? I am not talking about tobacco smoking. I am talking about only tobacco chewing in this slide. So if an examiner asks you to give level 1 evidence which links tobacco chewing to cancer, guys, you need to quote this. The meta-analysis by Guha et al. 2014. Meta-analysis by Guha et al. 2014. Once again, meta-analysis by Guha et al. 2014. Please memorize this evidence. Here are some important findings from this famous meta-analysis. It found, if a patient chews just sada pan, that is betel's leaf plus supari plus chuna with no tobacco in it, are these patients safe? Can we say that these patients are not at risk of developing cancer? No. Why? Because Guha's meta-analysis found the relative risk to be 2.5 if you chew betel quid even without tobacco in it. That means those who chew betel leaf plus areca nut plus slaked lime without tobacco in it are 2.5 times more likely to get cancer than a non-chewer. And this association is dose dependent. More chews per day, higher the risk. But what happens when you add tobacco to this? The risk doesn't just double, it explodes. The relative risk now jumps from 2.5 to 7.7. So remember these two important numbers for your exams. Betel quid without tobacco gives 2.5 times risk. Betel quid plus tobacco gives 7.7 times risk. Okay? Will you please remember this? There is another interesting finding of this meta-analysis. It found a gender disparity. What does it mean? When men consume betel quid and supari, their relative risk is about 5.3. But when women consumes the exact same combination for the same number of years, same amount per day, the risk of developing oral cancer in her jumps to 14.5. So 5.3 for male, 14.5 for female. That means the lady from UP or Bihar who comes to your OPD is at a much higher risk than her husband for oral cancer, even if she consumes the exact same amount as her husband. Keep that in mind when you take history. Okay guys, we talked about Betel Quid, which is our local Indian problems. Now let us look at the etiology of head and neck in global context. Smoking and alcohol. First, smoking. What is the evidence that smoking causes head and neck cancer? Do you know about it? The gold standard evidence here comes from the ENHANCE Consortium. ENHANCE Consortium. The full form is International Head and Neck Cancer Epidemiology Consortium. They published their report in year 2007. They showed that for a general smoker, someone who who smokes occasionally or even ever smoker, the relative risk is about 3.5 times. But if you have a heavy smoker, someone who smokes more than 20 cigarettes a day, the risk doesn't just double. It jumps to 5 to 25 times depending upon the severity and duration of smoking. This is the number you need to quote in your exams and case discussion. Relative risk for heavy smoker, 5 to 25 times. Now let us talk about alcohol. This is where most residents get confused. Again, we have a similar question. What is the evidence linking alcohol consumption and head and neck cancer? Listen very carefully. The best evidence comes from a very famous and highly cited meta-analysis called Bagnardi meta-analysis published in 2015. Bagnardi meta-analysis published in 2015. This is a massive evidence looking at 4,86,000 cancer cases. You cannot argue with this set data. Look at the table. Bagnardi divided alcohol drinkers into 3 categories depending upon the amount of alcohol they consume daily on an average basis. First category is light drinkers, those who consumes less than 12 gram of alcohol. It is called as one standard drink. We will deal with how to calculate this gram soon. Second category is moderate drinker, someone who drinks between 12 to 50 gram, that is 2, 3 or 4 standard drinks of alcohol. And third category is heavy drinkers, those who consumes more than 50 gram or more than 4 drinks. Focus on this table. This data comes directly from Bagnardi meta-analysis. See, this table tells us a very scary story about dose and response relationship of alcohol. Row number 1, you see light drinking. Look at the relative risk. It is 1.1. What does this mean? It means even if you drink just one standard drink a day, your risk is 10% higher than a teetotaler. It is not 0. Safe alcohol is a myth, at least for head and neck cancer. Row number 2, moderate drinking. Look at the risk now. It has gone up to 1.8. You're almost at double the risk of a non-drinker. Now look at row number 3, heavy drinking. Look at what happened to these numbers now. It doesn't go to 2.5 or 3. It jumps straight to 5.1. Did you see the jump? From moderate to heavy, the alcohol intake only increased slightly, but the risk tripled. This is what we call an exponential rise. So, the clinical takeaway is this. When you are counseling a person who is a heavy drinker, your first goal should be to get him below that 50 gram threshold. Because once he come down to moderate drinking, from heavy drinking to moderate drinking, the relative risk of his developing oral cancer drops from 5.1 to 1.8. Clear? Now look at this table. This is a sort of cheat sheet I have prepared for you to remember. See, most patients in India do not say, I drink these many standard drinks. They drink according to the local theka liquor shop measurements. We need to decode what they are saying. Here is the formula to calculate how much ethanol a patient is consuming. Before that, look at this table. This is for all those of you who do not drink. There will be very few only, by the way. Those who do not drink may not know the common terminology of Indian drinks. As an oncologist, we should know these terminology because that will help you in risk categorization. When you say small pack means 30 ml. When you say large pack, it contains 60 ml of alcohol. Patiala pack, late actor Dharmendra's favorite drink, 120 ml. Some say it is 90 ml, but most common consensus is 120 ml. Then there is a pawa or quarter, 180 ml. Then adha, half, 375 ml. Then khamba, generally a full bottle of 750 ml. It is important to know these because this is what a common low socioeconomic class patient say when you take history of alcohol consumption. Here is the formula to calculate how much ethanol a patient is consuming. Step 1. First ask patient how much volume of a particular alcohol drink he takes daily on average. For example, 30 ml, 60 ml, quarter, adha, khamba. Step 2. You find out how much of that is actually alcohol. As an oncologist, remember this general rule. Standard beer contains 5 to 7% alcohol. Strong beer contains 8% alcohol. And Indian spirits such as whiskey, rum, vodka contains 40% alcohol. Step 3. Now you multiply by 0.8 to convert that liquid volume into solid weight. So the formula is volume of alcohol drink consumed daily in ml multiplied by percentage of alcohol in that drink multiplied by 0.8. Once again, volume of alcohol drink consumed daily in ml multiplied by percentage of alcohol in that drink multiplied by 0.8. Here in row 1, you have small pack. If a patient says, doctor, I just take one small pack of whiskey, rum or vodka, he means 30 ml. Now do the math. 30 ml into 40% into 0.8. That is roughly 10 gram of alcohol. He is called light drinker. If he stops at one drink, his relative risk of having head and neck cancer is 1.1. Look at row 2, the large pack. This is the standard unit for social drinker, 60 ml daily. Do the math again. 60 ml into 40% into 0.8. This is roughly 20 gram of alcohol. He is called moderate drinker. His relative risk of developing head and neck cancer is 1.8. Now look at row 3, the quarter, pawa. This is the most dangerous category of drinkers. The quarter or pawa is the standard unit for daily wage laborers and heavy drinkers in North India. It is 180 ml. Do the calculation. 180 ml into 40% into 0.8. 60 gram of pure ethanol. Remember the Bagnadi threshold. Anything over 50 gram is heavy drinking with a 5 times risk of developing head and neck cancer. So mark my word, a patient who drinks just 1 quarter a day, is already in the highest risk category. He is a heavy drinker. To all those who think or who take only 30 ml per day on average and thus are not at risk, then listen carefully. It may be true for cardiovascular point of view, but not for head and neck cancer. Even 30 ml is causative. So there is no safe limit for alcohol. Remember, Bagnardi meta-analysis. Don't argue with Bagnardi meta-analysis finding. By the way, for your kind information, a recent meta-analysis found that even one drink per day can slightly raise systolic blood pressure with no safe minimum threshold identified. And in fact, the latest guideline for 2026 on hypertension says to avoid alcohol entirely. Now let us switch to another favorite drink, beer. Look at row 5. The strong beer, सबकी favorite Kingfisher Strong. Many patients and even some doctors think beer is safe. Not in India. Our patient generally drinks 650 ml of strong beer, which contains 8% alcohol, as I told you earlier. Now do the same math again and find out the actual amount of alcohol in grams. 650 ml multiplied by 8% multiplied by 0.8, roughly equal to 42 grams of alcohol. Think about that. One single bottle of 650 ml of strong beer has double the alcohol of a large pack. Large pack had 20 grams. So these people who are drinking a single bottle of 650 ml of strong beer are sitting right at the edge of heavy drinking limit. If he drinks 2 bottles, he has consumed 84 grams of alcohol. This is massive exposure. So the clinical takeaway is, when taking history from a patient, don't just write occasional alcohol. Ask, you take small peg, large peg or quarter. Ask, if he takes beer, ask standard drink or strong beer. That detail changes the risk assessment completely. Alcohol is not just a risk factor. Think of it as a solvent. If someone drinks heavily, their risk is 5 to 6 times higher. But the real problem is not the alcohol alone. It is the synergy with tobacco. Alcohol does not come alone often. It comes as a package. Smoking and drinking are often combined. This is a very important Viva question. The relationship between alcohol and tobacco is not additive. It is not 1 plus 1 is equal to 2. It is multiplicative. The risk of developing head and neck cancer is many folds higher if someone has both risk factors. Why there is multiplicative effect? Basically, alcohol acts like a solvent. When you take alcohol, it washes away the protective layer of mouth and makes the mucosa permeable to carcinogens from tobacco. So the carcinogens from tobacco, the nitrosamines, they penetrate the oral mucosa much faster and deeper, thereby putting a person at very high risk of cancer. So 1 plus 1 is not 2 here, 1 plus 1 becomes 10. That is why the patient who drinks and smokes is your highest risk patient for developing cancer. This is the summary showing relative risk of all the etiological factors. You are supposed to know the ones in yellow. No need to remember ones in green. Cigar, pipes and snuffs are not common in Indian population. They are common in Western countries. Betel Quid without tobacco, 2.5. Betel Quid with tobacco, 7.7. Cigarette smoker, general or ever smoker, 3.4. Cigarette smoker, heavy, 5 to 25 times. Alcohol, heavy, I told you more than 50 grams per day, 5.1. Next, we need to understand the exact molecular pathway of how tobacco smoking causes cancer. This is the difficult part of this lecture. Not that it is difficult, but because every book explains it in their own style. Remember, we are talking about mechanism of smoking in this slide. We are not talking about mechanism of tobacco chewing right now. We will talk about tobacco chewing in the next slide. Many examiners, especially at TMH, they love to ask this question during case presentation and viva. This standard question is, tell me doctor, how exactly does smoking lead to oral cancer? And the resident fumbles and utters some word, sir, smoking, mutations, DNA damage, and then cancer. Examiners get irritated if you don't know it well. Even though you may be knowing every detail of the types of resection, reconstruction, IMRT, and every latest trial under the sun. See friends, as oncologists practice in India, we cannot just give a vague answer about mechanism of oral cancer. We are not at MBBS level where it is sufficient to say oral cancer are caused by smoking, tobacco and alcohol, and then silence. We at oncology residency level need to know more. Especially in India, again I am telling you, especially in India where head and neck cancers are very, very common. We must know the exact mechanism. Concentrate and pay attention and listen carefully. You can listen to this part of the video in YouTube by setting slow playback speed to 0.75 if you feel the need. Ready? So the mechanism is like this. When a person smokes a cigarette or bidi for the first time, he is basically taking nicotine. Please understand, nicotine itself is not a carcinogen. Nicotine itself is not a carcinogen. But what it does, it binds to the acetylcholine receptors in the brain and gives that person a kick. This kick is what makes a person buy the packet of cigarette every day. It thus creates a dependency over this kick, and this dependency converts gradually into addiction. Listen carefully what happens next. Cigarette contains over 7,000 chemicals when burnt, and almost 70 of these are proven to be carcinogens. The most important ones for us are PAH, polycyclic aromatic hydrocarbons, and nitrosamines. There are many types of nitrosamines, but you need to remember two, NNK and NNN. If you forget NNK and NNN, you need to remember at least nitrosamines. Right now, these nitrosamines are pro-carcinogens. That means they are not toxic yet. Two things can happen to these nitrosamines, pro-carcinogens. One is a good thing. Our body tries to get rid of them. Our body's normal enzymes, specifically cytochrome P450, try to process or detoxify these pro-carcinogens and excrete them out of the body. This is a good thing to happen, and this process is called metabolic detoxification. Metabolic detoxification. If this happens, the person who is a smoker is safe. This is the critical step, metabolic activation. Our body's enzyme, cytochrome P450, while trying to process these pro-carcinogens, accidentally turn them into highly reactive agents. These nitrosamines, pro-carcinogens, are now get activated. This step is called metabolic activation. Next is the most important event on this entire slide. DNA adducts formation. The activated carcinogens attack DNA helix. It binds with DNA, forming a DNA adduct. DNA adduct. DNA adduct. Remember this word. Think of it like putting a piece of gum on a zipper. The DNA is now physically blocked or distorted. Normally, even if DNA adducts form, we have DNA repair enzymes. If they work well, you still get normal DNA and nothing happens. But sometimes when the cell tries to divide, the DNA polymerase hits this DNA duct and DNA polymerase gets confused. It puts the wrong base pair in. For example, an adenine becomes a thymine. This is called miscoding. If this is not fixed and persists, it becomes a permanent mutation. So this step is called persistence miscoding. Where do these mutations happen? In the genes that control cell life and death. For example, RAS genes, TP53 genes. TP53 is like a brake in a car, and RAS is like an accelerator of that car. When there occurs mutation in them, brake is cut and the accelerator is stuck. The result is now you have a cell that grows uncontrollably and refuses to die. This step is called mutations in important genes, and these mutations ultimately become cancer. There is another mechanism of how smoking can cause cancer. This is less dominant pathway. Look at this top pathway. This is where a nicotine and an NK act directly without damaging DNA. They bind to receptors on the cell surface. This triggers survival signals inside the cell like AKT. It tells the cell survive at all cost. What is the result? Apoptosis goes down. The cell will not commit suicide. Angiogenesis goes up. The tumor builds its own blood supply. Finally, there is another pathway by which smoking can cause cancer. This is less important pathway. Smoke contains irritant that are tumor promoters. These create chronic inflammation. These promoters activate pathways like protein kinase C, PKC. This creates a fertile soil for cancer to grow. So all three roads converge here. The central pathway mutates the DNA. This is the must remember pathway for you. The upper pathway prevents cell death. Try to remember this pathway. The lower pathway promotes growth. You may forget this pathway right now. The result is invasive cancer. Dear friends, the flowchart we just reviewed with co-carcinogen activation, AKT signaling and PKC activation is the gold standard mechanism of how smoking leads to cancer. It is comprehensive, but I know it looks complicated. Go back 3 to 4 minutes back and replay this video multiple times to understand it better. In the stress of a viva, you might struggle to recall every signaling pathway. So I have simplified it for you. If you can't remember the complex chart, if you can remember the complex chart, excellent. But if you cannot, you must memorize at least this simplified version of previous slide. This is the bare minimum. So I have created this simplified 6-step pathway. If you cannot explain these 6 steps in an exam, that means you do not understand tobacco carcinogenesis. Let us go through these 6 absolute essentials. Step 1. Smoking initiation, smoking addiction. Step 1 is a hook. This is nicotine. Nicotine does not cause cancer directly. Its only job is addiction. it forces the person to go to shop and buy a packet of cigarettes again and again. This literally means he keeps coming back for his toxic doses of smoking. Step 2, carcinogen exposure. Step 2 is the villain in the entire mechanism. Once the patient inhales over 60 carcinogens enter the system. The two most important ones you must remember are PAH and nitrosamines like NNK or triple N. Right now, they are just floating in the blood. They are not dangerous yet. Step 3 is metabolic activation. Step 3 is the accident. Metabolic activation. The body's enzymes, specifically cytochrome P450, try to clean these chemicals up, but sometimes they fail. Instead of neutralizing them, they turn them into highly reactive ticking time bombs. Step 4 is DNA ducts. Step 4 is the damage. This is the most critical event in the entire mechanism, the DNA adduct formation. The activated toxin attacks the DNA helix and binds to it. The DNA is now physically blocked. Step 5 is a critical mutation. Step 5 is the broken guardian. When the cell tries to replicate, the DNA polymerase gets stuck on the DNA adduct. The cell makes a mistake in reading the code. This causes a permanent mutation. Usually this breaks the P53 genes, the guardian of genome. Now the cell has lost its break. Step 6, uncontrolled growth. Step 6 is the result. When the brake is gone, P53, and accelerator is stuck, RAS, the cell grows uncontrollably. It refuses to die. It multiplies and invades. This is cancer. To summarize it even further, addiction leads to exposure, exposure leads to adducts, adducts lead to mutations, and mutations lead to cancer. So this is all about how smoking causes cancer. I hope you got some idea now. Remember, don't read from any other book now. You will surely get confused. Try to remember my flowchart. Okay guys, now let us move to the Indian context. How does chewing tobacco causes oral cancer? We learned about smoking in the previous slide. Is the mechanism of tobacco chewing the same as smoking? The answer is not exactly. The molecular principle is similar, but the delivery is completely different. So step 1, nicotine addiction. You have to understand the physical reality of what the patient is doing when he is chewing tobacco. When a person places khani or gutka in their gingiva buccal sulcus, they are not just chewing it, they are essentially parking it there. Because the tobacco is continuously touching that specific mucosal spot, the concentration of nitramines at that particular location is massive. It is much higher than what you would find in the blood. Eventually, that patch of oral mucosa is being bathed in carcinogens 24/7. Step 2 is the chronic irritation. Here comes the role of lime, chuna. Most patients add lime, calcium hydroxide, to the tobacco. This raises the pH inside the mouth. Physiologically, this high pH does two damage. First, it makes the mucosa more permeable. So this helps nicotine absorb faster, giving the kick. But it also forces carcinogens deep into the tissue. Second thing it does is the chemical burn. Because of this slaked lime, there occurs chronic inflammation. So you have two events happening simultaneously for many years. Continuous exposure, continuous carcinogen exposure, coupled with chronic inflammation, exactly happening at same spot. Step 3 is metabolic activation. Once the nitrosamine get absorbed into the cheek mucosa cells, our normal cells and good local enzymes, specifically CYP2A6, try to metabolize it. Note this enzyme name, CYP2A6. It is present in the oral mucosa itself. But here is the tragedy. In the attempt to clear the chemical, the enzymes make a fatal mistake. It activates the nitrosamine into a highly reactive species called diazohydroxide. Diazohydroxide. This is the reactive species. Step 4 is the DNA adduct formation. This reactive species, diazohydroxide, immediately attacks the DNA. It sticks to the DNA and forms a specific block called DNA adduct. One of the commonest type of DNA adduct is the POB adduct. POB stands for pyridyl oxobutyl. No need to remember it. You just remember it is basically a type of DNA adduct. Think of this POB adduct like a physical speed bump on the genetic code. Step 5 is replication error. When the cell tries to divide and copy its DNA, the copying machinery trips over the speed bump. It cannot read the code, so it inserts wrong base. This leads to a permanent mutation, specifically targeting p53 genes. And over time, these accumulated mutations turn that mucosal spot into a frank oral ulcer. So the sequence is very specific. Parking of the tobacco in GB sulcus, lime in it increases absorption, local enzyme CYP2A6 activates the poison, POB adduct blocks the DNA, mutation lead to cancer. This is why the cancer happens exactly where the patient keeps the tobacco. It is a local tragedy. I know you must be tired by now hearing this boring topic. But come on guys, we need to know about just one more last etiology. It is alcohol. Things are pretty simpler for alcohol than smoking and tobacco. We know alcohol causes liver cancer. But how does it cause oral cancer? The mechanism here is different than the liver. In the liver, it is a metabolic issue. In the oral cavity, it is a local attack. It happens right on the surface of mucosa, oral mucosa. When a patient drinks alcohol, it doesn't just get absorbed from oral mucosa and reach liver through blood circulation. It stays in the saliva for some time. The normal oral microflora in our mouth, oral cavity, the bacteria and the yeast living normally in the mouth possess the enzyme alcohol dehydrogenase, ADH, alcohol dehydrogenase. These bacteria convert ethanol in the saliva directly into the acetaldehyde. These bacteria convert the ethanol in the saliva directly into acetaldehyde in the oral cavity itself. But here is the danger. The bacteria cannot break the acetaldehyde down further. So the acetaldehyde keeps on accumulating in the mouth. The concentration of acetaldehyde in saliva can be 10 to 100 times higher than the blood. The oral mucosa is being bathed in a concentrated carcinogen, far more toxic than what the liver sees. This leads to DNA adducts and mutations in the epithelial lining of oral mucosa. This is the main mechanism how alcohol causes oral cancer. There is another contributing mechanism. This mechanism happens in those people who consumes both tobacco and alcohol. Listen, alcohol acts as a solvent. The oral mucosa has a protective lipid layer. The alcohol dissolves this lipid layer and causes mucosal atrophy. Now mucosa becomes permeable. It opens up the door for carcinogens coming from tobacco, such as nitrosamines, to penetrate the mucosal layer deeper and faster. And then these carcinogens follow the mechanism as saw in tobacco carcinogenesis slide. There is another mechanism how alcohol causes oral cancer. Alcohol interferes with retinoid, vitamin A metabolism. Alcohol interferes with retinoid, vitamin A metabolism. How does it matter? Because retinoic acid is required for our daily normal cell differentiation. When alcohol interferes with retinoid, vitamin A metabolism, the mucosa runs out of retinoic acid. The cells become immature. They start hyperproliferating. They lose their discipline, and this leads to dysplasia and eventually may convert into carcinoma. So if the examiner asks, how does alcohol cause oral cancer? Your answer should be, sir, it is a 3-hit mechanism. High local acetaldehyde production by oral bacteria, increased permeability to other carcinogens, local and nutritional depletion causing loss of differentiation. This is the complete answer. Okay guys, let us wrap this up. I know there was a lot of heavy science just now in previous 5-6 slides. We talked about many enzymes, pathways, DNA damage, flow charts. It gets complicated. And honestly, when you are busy in OPD seeing patient, you won't be thinking about these specific enzymes every minute. But trust me, this science matters. It explains what we actually see in the clinic every day. The main takeaway message is this. Oral cancer is almost never just bad luck. Many other cancer could be bad luck, but for oral cancer, there is a clear cause for it. It is very much preventable disease. Think about the tobacco chewers. They park the tobacco in one spot in the cheek. It causes chemical burn right there all day long. Or think of people who consume alcohol. It is scary that how our own mouth bacteria turns a simple drink into cancer. These are not just theories. It is actually happening inside our mouth when we consume these substances. Also remember that here in India, our patients are different. It is not just cigarette smoking, how you see in the West. We see so much damage from areca nut or the lime they add to the gutka. Why did we spend around 20 minutes on this topic? Why does it matter? Because it changes how we treat the patient after treatment. Remember the concept of field cancerization. It means the whole lining of the mouth or upper airway digestive tract is damaged from years of habits, not just the spot where the tumor was. Look, our job does not end after the surgery or radiation is finished. We need to know why the cancer happened so we can try to stop the next one. We have to keep counseling our patient and keep checking them closely for years on follow-up. Because if you don't address the root cause, we are basically just waiting for the recurrence. Thanks for your patience listening today. Stay tuned, subscribe to this channel and press notification bell because next topic I'm going to discuss is diagnostic workup for oral cancer in a day or two. Trust me, it won't be as boring as this lecture.